Much. Good morning, buongiorno, ladies and gentlemen. Thank you very much for the invitation to come to your beautiful country and the overwhelming hospitality. I'd like to speak a little bit on the situation in Germany and our experiences in Erlangen. So, where did the first World Congress on Pain take place? You can see it here. It was in Florence, 1975. So the first were the Italian people who had that Congress. And it will come back next year, the European Pain Congress to Florence, and this year to Milano, the World Congress. So you have a lot of pain congresses here, much more than in Germany. I come from Erlangen. That's a university city north to Nuremberg. And we have about 30,000 students. We have a university hospital and a pain clinic, and perhaps you know we have Siemens. So that's all of Erlangen, a 100,000 inhabitant town. We started pain therapy around 1998, 89. This was our first patient, a child with patient-controlled anesthesia. We were younger, we were 2 or 3 guys there. And with time we developed, and we have an acute pain service, pediatric pain service, we have palliative care teams, we have a pain clinic with multimodal programs, and we have research teams and do randomized control trials and all these kind of things. And it changed a lot. We have more and modern electronic devices for documentation for all of these things, and we're a big team now. So we have pain specialists. You have to work 1 year in a pain clinic in Germany to become a pain specialist after you have become an anesthetist or neurologist and so on. We are anesthetists, we are neurologists, we are orthopedic surgeons, we have psychologists, psychiatrists, and training sports therapists. So this is the first thing I want to say that changed dramatically, and I think an interdisciplinary approach is necessary for chronic pain to win 1-0, or here in Italy better 2-0, and then you have really a good chance. So this is a major point for treating patients with chronic pain. I'd like to talk a little bit about the mechanism-based application of drugs and the rationale. I'd like to talk a little bit of opioids and in various situations, just briefly children and elderly patients, and at the end a little bit about psychosocial consequences, multimodal programs. First of all, we all know that this is the often cited study by Breivik, a computer-based interview of pain patients, and here you have, this is I think important, the percentage of total population reporting inadequate pain control, 40%. Here we have Germany and Italy close together. So in every European country there's much to do, and the question is what? And one difference, as we all know, is here between Germany and Italy in this telephone interview, more NSAIDs in Italy and more opioids, here weak opioids, and 4% of the patients got strong opioids. So this is a difference. We use more opioids, as we just heard, and it's pretty obvious. So the first thing is, we changed a little bit what we try to teach general practitioners and other doctors. The pain letter, did a good job in promoting cancer pain and in promoting the use of opioids in cancer pain patients, but it's not as good for chronic non-cancer pain because we have a lot of new knowledge regarding physiological things, pharmacological things, and pathophysiological mechanisms. And that's not quite adequate in this letter, for example, always to use non-opioids even in step 2 or 3 and so on. And therefore, we try to go over to a more pathomechanism-based therapy, something like a router. We all know that from our cars, that we can, from the pain character and pain symptoms, that we can demonstrate that what are the mechanisms and then what is the best pain therapy. And if we take a look into that just briefly, we all know that we have pain syndromes like osteoarthritis, rheumatoid arthritis, affecting muscular system, the skeletal system, often exertion dependent, local and tender, sometimes with a lot of signs of inflammation as in inflammatory arthritis. Then we have all these neuropathic pain syndromes, polyneuropathy, postherpetic neuralgia, burning, shooting, and we have something like fibromyalgia or somatoform pain disorders, multilocular, without adequate pathological findings and difficult to treat. And then we should ask, what are the mechanisms? And we are far from definite answers, but we learned a lot that in this musculoskeletal pain, that's a nociceptive pain, an inflammatory pain sometimes, and we have the activation of nociceptors and even more sensitization. In the neuropathic pain, it's rather difficult, and we have channels and receptors that change, and we have a lot of central sensitization and reduced endogenous pain inhibition. And again, this reduced pain inhibition we can find in this, I call it, dysfunctional pain syndromes. And then if we look at the drugs, then of course we have non-opioids and in the inflammatory pain syndromes, glucocorticoids, but we can use opioids or even the new MOR NRI like tapentadol. In neuropathic pain, of course, we use anticonvulsive, antidepressants, opioids, and tapentadol, just different, but usually no non-opioids. And we have very limited therapeutic drug options in this dysfunctional pain, fibromyalgia, and so on. This knowledge is not used widely in Germany, because if you look at the neuropathic pain, for example, then it would be good, for example, to use duloxetine as antidepressant or pregabalin. But what is mainly used for the treatment of neuropathic pain in Germany? Here, the old and slow and not very good acting, if at all, ibuprofen or NSAIDs. So we have pretty much the same problem if there is no approach according to the pathomechanism. On the other hand, if we look at the dysfunctional pain here, then we do not have very much drug options, and usually we have more problems, in this case, with strong opioids. So these patients have to be treated with other therapies. So taken all together, for example, if we look at back pain is very different according to the reason, according to the mechanism. It may be nociceptive, it may be nociceptive inflammatory, it may be neuropathic, or dysfunctional, and often we have that mixed pain. And in Germany, we often cannot succeed in pain therapy because we don't use this mechanism-based approach. So this is something I think what should be taught to general practitioners, to students, and so on, because it can help to improve things for patients. We all know about the side effects of NSAIDs and COXIBs, and we have that problem too in a lot of internal medicine wards. We have gastrointestinal bleeding, and we all have that problems with cardiovascular system and renal system, with a lot of contraindications already known 2005, and things change slowly. Nevertheless, we have a lot of opioids in Germany. We have the weak opioids, tramadol, and here a combination pretty specific for Germany, that's tilidin naloxone. We are not a codeine country. We have a lot of strong opioids, morphine, hydromorphine, oxycodone, fentanyl and buprenorphine patches. Usually the market is divided, 50% oral, slow release drugs, a lot of oxycodone, and 50% transdermal, a lot of fentanyl. And we have combinations of oxycodone with naloxone, we have a buprenorphine low-dose patch, and we have all these fast-acting fentanyl products for breakthrough pain. Do we need all these opioids? And the answer is we need them for opioid rotation. Opioids are different, receptors are different. We don't know that much. We made much studies on genetics and pain genetics, but we are far from anything we can use in our daily practice. But opioids and patients are different. We need different opioids for opioid rotation. And opioids are different in terms of side effects. And for example, in renal insufficiency, we all know that there might be problems with the morphine 6-glucuronide, which can accumulate. So it's better to use hydromorphone or buprenorphine, for example, but you can also use the other. You have to be a little bit cautious. Of course, there are differences between opioids regarding tolerance on the long term, regarding the immunological system, and all these kind of things. And the problematic thing is, in this case, morphine. Therefore, there's a tendency in Germany to switch a little bit from morphine to the other opioids. If you use it in chronic non-cancer pain, you have some criteria at the baseline. You should have a definite diagnosis of what pain you have, because it doesn't make any sense to you in psychiatric disorders, on the somatoform pain disorders, to use opioids. And usually you should have a goal, for example, reduction of at least 30% or 50% on this opioid therapy. So you should have goals. And there is a discussion in Germany, because the evidence of guidelines, randomized controlled trials, they terminate after 12 weeks. So we have little data by trials for opioid therapy longer than 3 months. But we all know that we have good responders for long-term opioid therapy, so there's always the discrepancy, the difference between trials on one hand and the experience on the other hand. Of course, there should be some performance criteria, especially the patient should be informed prior to treatment what is planned and what he should do, and whether there should be an informed consent, that is under discussion. And of course, there might be some discontinuation criteria, that's obvious, if there's no pain reduction, but also if there's no improvement in performance, more activity, more life quality, and all these kind of things. And then the opioid discontinuation should always be gradual. That's pretty obvious. So how to do opioid therapy, that's quite clear. That's not the point. It takes some time to talk to the patient. So the question is, what about communication? What about time for that? That's more the point, I think. So there might be really a successful treatment in case of careful patient selection and patient guidance. And therefore, opioid therapy has increased in Germany quite frequently. One of the next points is the side effects. And a lot of patients are not satisfied due to side effects. And therefore, we should try to improve things that the tolerance with these drugs are better. Less side effects and better tolerance of the drug could lead to a better efficiency and to better effects. And there are data that some opioids, here's tapentadol, for example, might have less side effects here, even in a randomized controlled study compared with oxycodone. So we have the chance to reduce side effects. And if we do so, we can achieve our treatment goals. But then we have to titrate the dosages of the opioids up. Often we stop at low doses, but if side effects are under control, then titrate it up, your opioids or your antidepressant or whatever, then probably we'll get to better results. We have a lot of fentanyl formulations in Germany as well, but restricted to cancer pain patients and breakthrough pain. And this is quite a good thing because we don't have, for example, for outpatients with cancer pain, we don't use that PCA in that amount. We used to do it 10 or 15 years ago. In children, there are a lot of deficits in Germany, especially post-operative, because there is problems with the assessment of pain, there are problems what dosage of opioids, there's fear of side effects, but clearly there are indications for strong opioids post-operatively for cancer pain in children. Usually that's something for specialists. Major thing, I think, is that we have a concept for outpatients, that we have something like a pediatric palliative care, not only in departments of pediatrics in the hospital or department of palliative care, but for outpatients. Here you can see here the team in Erlangen. So that even children with cancer and with a lot of IV drugs can live at home and die at home. And I think there much progress has been done in Italy as well as in Germany in adults and should be done in children as well. Major problem with therapy and with opioids is in elderly patients, because usually in Germany elderly patients with pain, they take 7 different drugs, and then we come with even more pain drugs. So the problem is the polymedication, and we should reduce this. Then the next thing is compliance with all these drugs. Therefore, a lot of elderly patients in Germany get transdermal opioids more than the younger ones. And again, usually we should start low and go slow, but we should go. We should not stop with low dosages of opioids. In Germany, general practitioners can prescribe strong opioids, and they do that quite often in these elderly people. A huge problem in Germany is people in pain with, who are cognitively impaired. And first thing is the assessment, and we have a German version of here the pain aid. This is a score of 0 to 10, trying to get out whether the patient with dementia has some kind of pain. There are other Dolo Plus or ECPA, other pain assessment instruments available. And it's more and more that it's mandatory for the nursing staff in the nursing homes in Germany to assess people with dementia with such a pain assessment instrument. And then they should be treated, and again, opioids would be a good option. And we have some hope, because there is a study from 2011. If you treat residents in nursing homes with a standardized pain protocol, in this case it was paracetamol and opioids, according to the guidelines of the American Geriatric Society, then you can significantly improve agitation, aggression, and pain, and you probably can reduce the unnecessary use of antipsychotics in those people. So elderly people and people with dementia should be treated, assessed and treated adequately, probably with opioids, and that is really a thing we should encourage. What about neuropathic pain? Here we have the opioids in the guidelines, and these guidelines are pretty the same in Germany as first-line drugs according here in periods of extreme pain intensification, acute neuropathic pain, neuropathic cancer pain, and in the induction phase of first-line medication. And often as specialists we have to combine these opioids with other drugs, and you all know we use antidepressants. And in Germany we have a lot of them, and still there is amitriptyline widely used, and it has a lot of side effects in elderly patients with the anticholinergic side effects and even the deterioration of cognitive function. More and more it's used, the SNRIs, so duloxetine and venlafaxine are increasingly used in Germany. What is more used in neuropathic pain are gabapentin and pregabalin. And it's about 50-50%, but it's widely used, especially pregabalin, which is more expensive in Germany, but it's far more used for pain indications than for any other indication, and even general practitioners use it in combination with antidepressants or with opioids in patients with neuropathic pain. The chronic pain patient has a lot of consequences. We have an impact on walking, on household chores, lifting, exercises, sleeping, not longer available for these patients. And that means every drug has to demonstrate that life quality, that activation and other things can improve with the therapy. And therefore, every new drug in Germany, here tapentadol, for example, as a new drug, has to demonstrate that it can improve life quality. And this especially regards to physical function, that we have to increase physical functionality, vitality, and all these kind of things. People have to become more active, and activation is the key of patients. They have to do something. And the drugs, opioids or whatever, should force them to do that. But sometimes, especially psychological things, cognitive function, there might be some deterioration with opioids. Therefore, we have to do that clearly in an individualized way. What patients think on chronic pain, and here you can read it from down. My family does not understand how my pain affects my life. My doctor does not think my pain is a problem. I do not feel like I have enough time to discuss my pain with my doctor. My employers and colleagues are unsympathetic to my pain. I think my doctor does not know how to control my pain. No one believes how much pain I am in. My doctor would rather treat my illness than my pain. So often patients are not quite satisfied with us. And there are quite a lot of things here. It's communication, it's pain and illness, so is how to deal with that. And that is a problem we try, and this is a major change in Germany, to fix that not only with drugs, but to go over to so-called multimodal treatment programs. And this means that that patients in these programs, they have to do a physical training, movement therapy, sports therapy. We have to activate those patients. Then we have a lot of other psychological things, psychological pain treatment, coping strategies, distraction, acceptance, mindfulness, all these kind of things that they can enjoy things in life and not only think of their pain, relaxation techniques, and education. And this is a major shift in Germany from pain therapy, from single and individual nerve blocks, for example, or whatever you want, to this multimodal programs. And this is what we can offer. But this is not the reality in Germany. We can do that in Erlangen or in some parts of southern Germany, but it's not all available all over Germany. And the reason is that it has to be financially reimbursed, and it takes a lot of people to take part in this treatment programs. So, I have some, it's time consuming, so that's my fast, I would be faster, but this is not fast enough. So in this time, in this pain clinic evaluation, we have a medical examination of 90 minutes, a psychological interview of 90 minutes, and we have a sports evaluation by the physiotherapist of 120 minutes, and then the team, all the team decides whether to treat this patient with drug therapy or as an outpatient or with multimodal programs or with an inpatient. And we can offer those programs for headache, for chronic pain patients, for pain in the elderly, and for patients with fibromyalgia. This is a major change, how to treat patients, multimodal with activity, sports training, and psychological training in contrast to former days. So to summarize, there's much to do in Germany regarding pain therapy. I think education should be the key, education of physicians, nurses, students, and all these persons. It's more an interdisciplinary approach. We have to consider mechanism-based application of drugs and of opioids. Adequate use of opioids can improve things in our patients. We have to consider children and elderly patients, and we have to consider psychosocial consequences of chronic pain and perhaps multimodal pain programs. But education would be the key. And I think then we can improve things as we did in a lot of, for example, cancer pain patients. And I think, therefore, there's hope that things will get better. So, thank you very much for your attention.
Please.